Please remember that at the end of the session, we will also have a short break in which any questions regarding to Dr. Andreas, Dr. Kelly, or Ms. Jayanti's presentation can be asked in the forum, and we will get the speakers to reply to your questions as soon as possible. Please stay logged in during the break as well. I would now like to call upon our next keynote speaker, Dr. Cazzato Gerardo from Italy. Dr. Cazzato, please proceed. Thank you.
Thank you very much. Good morning, everyone. I am Gerardo Cazzato, specialist since a month in pathology. For me, it's an honor to speak with you. My presentation will treat about a typical fibroxanthoma-like melanoma. That is a rare entity of melanoma. In abstract, a typical fibroxanthoma-like amelanotic melanoma is a very rare variant of melanoma that can, if not correctly recognized and framed, lead to diagnostic error that can potentially cause a problem of extreme relevance to patient. A correct knowledge of this entity and the execution of adequate immunohistochemical panel are the basic condition for a correct management of this lesion. We, therefore, report a case of a typical fibroxanthoma-like melanoma, which clinically simulated a fibrohistiocytic lesion, and which created, for pathologists and for dermatologists, differential diagnostic problems. And finally, we conduct a very short review of the current literature. In introduction, a typical fibroxanthoma-like amelanotic melanoma is described in English literature for 4 or 5 cases. Therefore, is a very rare form of melanoma, and the correct knowledge is of fundamental importance, because many problems in terms of differential diagnostic can be created. Yes. In particular, this melanoma can mimic many skin cancer and benign skin lesion, and its correct diagnosis is of fundamental importance for the nosographic classification of the lesion. Case history. A 93-year-old man came to the University Dermatology and Venerology Department following the identification of a lesion to the right auricle of approximately 1 centimeter in diameter that had been present for about 2 years. The lesion had been interpreted by the dermatologist as a fibrohistiocytic tumor without suspicion dermoscopical appearance. The lesion was excised, formally fixed, and sent to the University Pathological Anatomy Department. After sampling and paraffin embedding, some histological sections were routinely stained with hematoxylin eosine. The lesion was centered in the dermis, ulcerated, and made up of spindle cell with pleomorphic, hyperchromatic, and sometimes nucleolated nucleus, moderate to high eosinophilic cytoplasm, and arranged in fascicular, sometimes randomly fashion. There were also giant multinucleated Teuton-like cells, like a typical fibroxanthoma, especially in the superficial part of the lesion. But at higher magnification, several mitotic figures were observed of both typical and atypical nature, and there were outbreaks of peritumoral inflammatory lymphocytic infiltration. Phenomena such as necrosis, hair hole, and hemorrhage were not evident. The dermo-epidermal junction did not present any junctional melanocytic growth, and there were no significant alteration. On the other hand, the lesion was noted to make contact with the nerves surrounding them, arrows. The morphological characteristics were coherent with the diagnosis of a fibrohistiocytic lesion of a typical fibroxanthoma type family. However, some immunohistochemical tests were carried out in order to confirm this clinical and pathological diagnosis. The immunohistochemical tests were negative for CD10, positive in many atypical fibroxanthoma, together with the vimentin, CD68, CD34, and CD31. Immunostaining for SOX10 and C100 protein were strongly positive, including in Teuton-like cell, while the reaction for melanoma and HMB45 were negative. Immunohistochemical, this is S100 protein. Immunohistochemical tests for P14 and P63 resulted negative, and they were also carried out in order to exclude the possibility of a pseudosarcomatous squamous cell carcinoma. According to the immunohistochemical profile, the hypothesis of melanocytic lesion was suggested, and the specimens were re-evaluated in the light of this new hypothesis. Some positive mast cell, CD170 and tryptase, as well as some small nerves deep down in the lesion, were identified. Therefore, the diagnosis of neurotropic melanoma with diffuse phenomenon of desmoplasia was made. Discussion. Melanoma is one of the most aggressive malignancies. Its correct identification and consequent diagnosis is of fundamental importance in order to correctly manage the patient. Melanoma can mimic many different tumors, such as dermatofibrosarcoma protuberans, or malignant fibrohistiocytoma, or myxofibrosarcoma, malignant hemangiopericytoma, and malignant schwannoma, which leads to many problems for the pathologist. In particular, we describe a case of a very rare variant of melanoma with morphological characteristics similar to atypical fibroxanthoma. This variant has very rarely been described in literature, with only 5 cases found in research published on PubMed and Medline. More specifically, 5 cases by various authors have been described, all in elderly patients, more than 65 years, in parts of the body exposed to sunlight, hand and neck, for example, and in at least 2 cases, just as in ours, the clinical hypothesis did not take into account the possibility of melanoma. Comparing our case to those reported in literature, in 2 cases, the immunohistochemical markers S100 protein, melanine, and HMB45 came out completely negative, making the diagnosis even more difficult. Our case presented high positivity for SOX10 and S100 protein, which allowed us to come very easily to the hypothesis of a melanocytic lesion. Another very important aspect consists in the fact that the lesion in our case had a large maturation, making it impossible to identify an area of melanocytic junction proliferation that would have helped the diagnosis of melanoma, also using hematocileucin. The diagnostic clue in our case was the finding of some small diplo embedded nerve and the presence of a few mast cells that are characteristic of neurotropic/desmoplastic melanoma. Also, morphologically, the lesion mimicked an atypical fibroxanthoma. Negativity for CD10, CD68, and vimentin was not in agreement with such a diagnosis, and the simultaneous negative result for melanA and HMB45 made the diagnosis even harder, making a potential different diagnosis between primitive or metastatic lesion was practically impossible, insofar as the absence of melanocytic junctional proliferation did not allow us to be certain the primitivity of the tumor. Even through imaging examination, such as RMI, did not reveal tumor in other areas of the body. Finally, we have described the 6 rare cases of atypical fibroxanthoma-like amelanotic malignant melanoma, which is a very rare entity that can be difficult to diagnose. Correct immunohistochemical testing, together with the knowledge of the existence of such a variant, is of fundamental importance so as to correctly identify the lesion, hence avoiding incorrect diagnosis. Thank you very much. This is images, my images. Saluti da Bari.
Very thanks from Bari.
Esatto. And for collaboration, there are a Facebook page, Instagram page, and my email. Thank you very much. See you soon.
Thank you very much, Dr. Gerardo. That was a very interesting case. I think after bringing it to our notice, I am sure the histopathologists are going to look for more and more of these lesions. We do know that melanoma is one of the greatest mimickers ever known and can mimic a vast spectrum of soft tissue as well as epithelial appearances. With that in mind, thank you very much for a very informative and rare case. And I would now like to